She's fierce, she's loving, she's a boss, she's giving sisterhood, support, and service. Mocha Mom. She's fierce, she's loving, she's a boss, she's giving sisterhood, support, and service. Mocha Mom. She is, yeah. She is Mocha Moms. She is, She is Mocha Moms.
Good evening, Mocha Moms and friends. We are so excited to have you with us today. Welcome to Understanding Genealogy and the Importance for Mothers of Color in Medical Research in partnership with the National Institutes of Health, All of Us Research Program. My name is Quay Noel Kelch. I am National President of Mocha Moms. Mocha Moms Incorporated is the premier voice for mothers of color. Through chapters nationwide in Hawaii and online, Mocha Moms provide support for women of color as they journey through all phases of motherhood while advocating for them nationally. Our focus is sisterhood, support, and service. We host weekly sister socials, moms nights out, social events, conferences, community service events, and much more. To join our sisterhood and find a local chapter in your area, please visit us at mochamoms.org. So before we jump into our topic for this evening, I encourage you to engage in the chat. We will have Q&A at the end, but if you have any comments, if you have anything to share, feel free to use the chat function to share any of your thoughts. Mocha Moms is excited to partner with the National Institutes of Health All of Us Research Program. All of Us is working to improve healthcare through research. Unlike research studies that focus on one disease or group of people, All of Us is building a diverse database that can inform thousands of studies on a variety of health conditions. This creates more opportunities to know the risk factors for certain diseases, figure out which treatments work best for people of different backgrounds, connect people with the right clinical studies for their needs, learn how technologies can help us take steps to be healthier. The All of Us Research Program is part of the broader Precision Medicine Initiative. So tonight we have the pleasure of hearing from Dr. Priscilla Pemu. Dr. Pemu is a professor of clinical medicine, associate dean for clinical research, and director of the Clinical Research Center at Morehouse School of Medicine. Dr. Pemu is an internist whose goal is to improve the health of all patients, similar to those that she encounters in her primary care practice. The complex interplay of patient, physician, practice setting, environmental, and psychosocial factors in perpetuating disparities in health incomes led to her interest and work with the Community Physicians Network. In the past 15 years, we have developed a successful partnership based on a shared vision for improved care and outcomes among minority and underserved patients with community physicians who are part of the Morehouse Community Physicians Network. The overall focus has been on identifying gaps in treatment and outcomes and opportunities for improvement. As medical director of the Community Physicians Network, she is responsible for planning and executing research and quality improvement initiatives. CPN established several disease-specific registries for hypertension, diabetes, heart failure, and metabolic syndrome of 6,500 individual patients. These were used to support research and quality improvement initiatives. Dr. Pemu is the Morehouse site PI for the All of Us Health Provider Organization called SEEC. The Morehouse site enrolled over 5,000 full participants, 95% of whom are African American in the program, by applying the principles of culturally congruent communication. She leads the Morehouse Participant and Clinical Interactions Unit of the Georgia Clinical and Translational Science Award. In this role, she's directly involved in ensuring quality and efficiency of clinical research studies through training of staff, review, and prioritization of resources for clinical projects, and review of data and safety monitoring reports as the chair of the Institutional Scientific Advisory Committee. She is part of the team at Morehouse College, Morehouse School of Medicine, that developed a system and method for chronic illness care that empowers patients to change behaviors relevant to their health through improved knowledge, support for goal setting and accountability in sustaining behavior change. Dr. Pemu completed a residency with the TED organization in May 2019. As a participant in this highly selective incubator for breakthrough ideas, she introduced the concept of culturally congruent coaching. Her TED Talk, featured as editor's choice on TED.com, shared the results of 12 years of research, observations about what predicts successful health behavior change. She's also the proud mother of 4, wife of 30 years, a sister, a friend, and a daughter. Please welcome Dr. Pemu.
Thank you so much. Good evening. It's a great honor to be asked to come and share with you all some information, insights around the All of Us research program and what is possible with that data as it's been assembled. So in my conversation today, we can kind of roughly divide it into 2 or 3 parts. One part will just be sharing the rationale for even participating in All of Us or for establishing this data set. And then in the next section, I'll talk about what kinds of data have been accumulated, what's available in terms of the data, where you can access it, what's available at different levels of access. And then we'll talk about the kinds of questions that we can now answer and why it's so important for all of us to know about this data. It's not limited to people with a science background. Anyone, one of the core values of the program is to engage participants as partners. So not just as people providing samples to build this data set, but also using it to ask and answer questions that matter to us in our community. So that's what we'll be doing in that last section, is it's kind of getting you to think about what kinds of questions you want to ask and figuring out how to go about doing that with this resource, which has been created and will be maintained with all of our tax dollars. Thank you for inviting me. I appreciate it. And we'll get started. So first slide, please. I bring you greetings from the Morehouse School of Medicine, where our mission is to lead in the creation and advancement of health equity for health justice. We have been on this path since our founding, and so it's not something that we come to lightly. It underpins all of the work that we do. With respect to this presentation today, I do not have any disclosures. Next slide, please. And so we'll go through, like I said, talk about the general framework of the program, discuss in detail what this unique resource is that we currently have at our disposal, and then talk through ways in which we can use this to answer questions that matter to us. Next slide, please. So, talking about why this matters, look at these 2 circles. The circle on my right that has a lot more light blue is a reflection of the distribution of information that we have in existence prior to the All of Us research program that has genomic data. If you look at that circle, you'll see that about 91% of the genomes that's available, that's been analyzed, that was existing in the world, was really those of people who are white or of European descent. The rest of the world population, people who are of Asian descent, only represent 5% of those databases. African Americans only represent 2%. People of African descent maybe in total 3%. If you add all together, people of Hispanic descent, less than 1%, and on and on. I think the point there is that prior to the All of Us research program, there are genomic studies, but their big gap is that they are not very representative of the world that we live in. And in the next few slides, I'll kind of share why that matters. because we hear a lot of people say we're more alike than we're different. Why do you want to insist that you have different kinds of people? I doubt that the Mocha Moms would have that question, but we will discuss why it matters. Um, Now, the circle on my left, I don't know if you can see my pointer, but the circle on my left essentially is what the distribution of data that's available from all of us is showing. So the all of us data, high level information is that over 80% of the data that's available in all of us is being provided by people that are categorized as underrepresented in biomedical research. So that includes people of color, people who are women, people who live in rural areas, people with different kinds of intersectional identities. So, all of us for race, ethnicity, if you look on that left hand side, you'll see that people who are Black or African American represent close to 18% of the data that's currently available. Hispanic, Latino, 16%. Asian people is kind of low, is 3.1%. People who are white or of European descent in this data set by design form about 51.8% of the data. Next slide, please. Right. And so the reason that it matters to that point is that when you only have, what do you do with genomic studies? You use it to try to understand people's risk for certain kinds of diseases or their likelihood of responding to different kinds of therapies. So we look at precision medicine as an opportunity to move to shift the paradigm from the ways in which we have discovered cures in the past, which relied on, oh, this is the average response that you can expect, to more tailored responses, which is for a person like me with my history, with my genealogy, what can I expect in terms of effectiveness for this therapy or my risk for getting this health condition? The way in medicine that we quantify those is referred to as polygenic risk scores. There are all kinds of polygenic risk scores that have been developed. Because we're using data sets that are about 80 to 90% people of European descent, what that does is that you do not have the same kind of diversity of the genomes that you're using to generate those scores. And so something that may be completely normal, but just has not been represented when it shows up will be identified as abnormal. What that does is it skews and it makes less valuable the polygenic risk scores that we have available. When you find a genetic variant in a person, if you don't have a nice, robust representation of those types of genetic variants, it's hard for you to tell what the meaning of that variant is. And so that's the argument for why precision medicine is really important and needed, and why the data in all of us research data set is really important as a step in that direction. Next slide, please. And so this just shows you in terms of, I said that UBR, the short term, I know we use a lot of alphabet soup, is the under people who are underrepresented, usually in biomedical research in the United States. And that can be women, people at the extremes of age. It can be by race, ethnicity. It can be sex assigned at birth, gender identity, sexual orientation, educational attainment, so people with less than a GED, income, if they're earning less than $25,000 a year, or geography, meaning they're in predominantly rural areas, or they have some disability, and people who are identified as sex and gender minorities. All of these categories are recognized as underrepresented in biomedical research categories. And so in all of us research data set, at the time that this slice was taken, this is the representation. It's not yet quite where we want it to be, but it's way richer than anything that we currently have, and it opens the door and allows us to ask a lot of important questions. Next slide, please. This is just a high level, sort of the scientific priorities of all of us research program, collecting all of this information with the goal not only to be able to explain what exposures and drivers are accounting for the health outcomes that we see, but applying interventions to try to shift that. So it's a very comprehensive scientific roadmap. And fortunately, we're at the point now where we're able to begin to implement those. For me, I think what is crucial and why I really appreciate this opportunity with the Mocha Moms is not just the opportunity to talk about what exists in the data, but I think that in addition to asking people to participate, I really want participation to be seen in a much more holistic way. So not just as people contributing samples, but as people who are able to use the data to ask and answer questions that matter. What I have experienced in my years at Morehouse is when you have people from our community engaging at every level, people ask questions that you or that would never be asked otherwise if they were not at the table and capable of using having the tools to ask and answer those questions. So I think is really critical. Next slide, please. And so here's, in general, the kinds of data that's available to all of us and what you can see depending on your level of access. And we'll talk a little bit about how to get to the different levels of access. So all of us has a public tier where you can look at data snapshots, and we're going to have a little road trip or show and tell where we can kind of play at in the website and you can see all of these yourself. Then there's a data browser that's interactive, so you can preview and look at what kinds of, so there's aggregates where it summarizes overall what kinds of responses are available, but you can also go in and see what were the questions that were asked and see how it's distributed. And there's the Survey Explorer and then Research Projects Directory, so you can kind of see the kinds of questions. Now we have over, I think, 3,000 studies that are actively going on, but it can be way more. And then there's the registered tier where you can have access if you specifically register and you're a known quantity. What do I mean by that? Basically, think about it, it's like a clear for research. So you go in and you provide your identity information and they verify that you are who you say you are. And once you do that and you take some training, you're allowed to get into the registered tier. The control tier lets you actually see individual level data. And to get access to this, you have to be part of an institution, and that institution has to have what's known as a data use agreement or DURA that allows you to get access. And that gives you access to specific genomic sequence data and things like that. Next slide, please. And so, you know, this also goes back to what I had shared earlier, specifically around, you know, we're more alike than we're different. But even though we look the same on the outside, we're very, sometimes, you know, you could be a healthy person, look just the same as someone with severe disease, look just the same as someone presenting with atypical disease, or with someone who has disease risk that's self-limited. We all walk around and we look the same. Next slide, please. What the reason it matters for us to be able to dig below the surface to understand people's risk is then you kind of figure out for whom a drug is beneficial, not by trial and error, but in a proactive way. I'm sure many of you have experienced drug toxicities, drug reactions, or you know someone who has had a bad reaction to a medication when other people did not. This, what we're looking for forward to with precision medicine is the opportunity to be proactive in finding those risks and identifying who's likely to benefit from a medication. You don't want to spend time taking a medicine just to find out that you're somebody for whom that drug does nothing, or that you take the medicine and you get toxicity, or that is beneficial and you have some toxicity. You want to predict that up front. And that's something that precision medicine would allow us to be able to do. Next slide, please. So the goal of the program is to enroll 1 million or more people across this country. Currently, the last time I checked, it was about 811,000 enrolled in the program. Now, enrolling in the program, and I'll share in a few slides what that looks like, what that process looks like. The data that we currently have available is from over 456,000 people, 80% of whom could qualify as underrepresented. About 50% of those are race, ethnicity underrepresented. Next slide, please. This is our group. Quay mentioned in the beginning that I'm part of the Southeast Enrollment Center. It's 4 institutions. We've been at this since 2018. University of Miami, University of Florida, Emory University, and Morehouse School of Medicine. So Florida and Georgia is our health provider organization group. And these are some of our partners. Next slide, please. So we're based at Morehouse, and we're working collaboratively with Grady Memorial System. Next slide, please. So this is what enrollment looks like in all of us. You can enroll through a health provider organization, which is what we are, or you can enroll as a direct volunteer. Enrollment, you can do that online. Join allofus.gov. Is it org or gov? Oh God, somebody help me. I'll show you in the end. Next slide, please. And when you choose to enroll, there are several steps. The first step, obviously, is going in and providing consent. You can do all of this online. When you go to that website, you go through the steps. It shows you, it explains to you what you're signing up for. You have to be 18 or older. Like Quay said, you don't have to have any particular health condition. You don't have to. All you have to be is 18 or over. And then you give different consents. There's consent to be a participant in all of us. And then there's a different consent for sharing your electronic health record. And then there's additional consent for genomics. And then you answer surveys. There's several surveys that you answer at baseline. They're the basics, the one that goes over health and lifestyle, healthcare access, utilization, family medical history, your own personal history. So all of those surveys are online as well. And then you can choose to go in person to a site if you're doing enrollment through a health provider organization. And those visits, these are the different items that are collected: your blood pressure, heart rate, height, weight, hip circumference, waist circumference, and body mass index. And we also then collect samples. If you do not go into a health provider organization, there's an opportunity, if you're far away from one, to actually request a kit. They'll send you a saliva kit, and you can collect your saliva and send it in after you've done the surveys. If you come into an HPO site, we collect your blood. If we're unsuccessful, we use saliva instead. We prefer blood because running genomic analysis with blood is way more informative and accurate than with saliva. And then there's this limited program to share information from wearables and digital apps. So that's what enrollment in all of us looks like. Next slide, please. And the kinds of information you get. So once you join all of us, you have the ability to download the All of Us app. In that app, you can see your results. So All of Us prioritizes return of results. So you get your results back. The first set of results that you get are the fun things. It'll tell you what your genetic background, more than likely where you're from. It'll also share information about your certain traits that are fun traits. Next slide, please. Things like, do you like cilantro? Do you have bitter taste perception? Things like that. Next slide, please. But then the more serious stuff. Next slide, please. It can show information. I guess I didn't put it in here. Information around your genetic predisposition to certain health conditions. Most people do not have those predispositions, but for those who do, if they participate in All of Us, they'll get a report of that. That's why there's a very deliberate and intensive consent process prior to getting return of results. You have to actually give permission to get those genetic results returned. And when you get them, if you need additional support to understand what they mean, so you're not just going to your doctor with a printout, you can actually, All of Us has a program where you can set up an appointment with a genetic counselor to go through that. So this talks about what happens to the data once people have donated their information, whether they be surveys, electronic health records, physical measurements, or any others. It's placed in a raw data repository. There's a lot of data curation that happens to clean the data and harmonization. And then it's in this curated data repository that we call the Research Hub. Access is through a secure Google Cloud-based platform, and we're going to play in that for a second. When I get there, I'll take you there. Next slide, please. So these are the kinds of data we currently have. I've kind of alluded to this. We have over 400,000 surveys completed, 245,000 plus genomics data sequences that are available, different kinds. We have physical measurements from 337,000 plus, electronic health records from over 450,000 participants, and then data from wearables from a sample of people of a little over 15,000. Next slide, please. The genomic data is, I told you those recreational genomics. So, where are you from? Where's your ancestry? How do you like cilantro or not? Do you have bitter taste perception? Things like that, simple traits. But then there's the more serious information, health-related genetics, the ACMG 59, and then pharmacogenomic data. These have been launched and released now. Like I said, the ACMG 59 it identifies susceptibility to certain genetically driven conditions. And when you get your report, you have access to set up an appointment with a genetic counselor to go through your information and plan out next steps. There's also a pharmacogenomics data that's provided. And what this looks like is it just explains to you how your body breaks down medicine. And so based off of your results, it can kind of tell you may not, be able to break down medicines that are in this category. You might be a fast metabolizer of medicines in that category and things like that. So that's the vision of precision medicine actually becoming practical. Next slide, please. So there is the public tier. If you hit the button, I think it's going to highlight this this bottom box. Can you highlight or just hit the next slide? Let's see what happens. Yes. So this data is available, and we're going to go there and look at it. The registered tier, like I said, you have to be a known person. It's like the clear that gives you access here. And the controlled tier is the one that lets you actually get individual data, including genomics data, and you have to have an institutional data use agreement to have access to that. We're not yet having the individual biospecimen and participant data access, but it's in the future. Next slide, please. So what does it look like? So this is the website, www.researchallofus.org. We're going to go there in a little bit, but let's go through the next few slides and then I'll take you on a little road trip. Next slide, please. So here's what's in the Research Hub. Next slide. There is what's known as the data browser, where you can ask questions and see what kinds of data exists, whether it's EHR data, whether it's lab data, whether it's medication data, whether it's symptoms that people complain about when they go in the hospital. It gives you an aggregate and counts. And then there are the data snapshots that tells you on any given day or week how many people are enrolled, what those people look like, what kinds of data elements we have. And that's where the information I shared around, we have X amount of survey data, we have X amount of genomics data and all of that. You can see that as well in the data snapshots. And then we have the research projects directory, where you can see the different kinds of research that's currently going on. And if you wanted to read specific research, you can go find those. And then they have research spotlights. You know, the program spotlights certain kinds of research that they find interesting for people to draw people's attention to. Next slide, please. So, data browser, open to everyone. It provides summary statistics. It's open to everyone, like I said. It helps you to understand what we have available. So I think we should go there now. I think, am I allowed to share my screen now? I'm gonna guess, yes, I can share real quick. I'm supposed to share data browser. Tell me if my sharing makes sense. How do I know? Let me come back here. All right. Someone let me know what you see. Okay, I see what you see. All right. So coming back here, let me show you. So remember I said you can kind of go through this and see the different kinds of data. There's information about the Research Hub. You can see all of the institutions that are registered. It tells you in detail what our privacy and security protocols are. And then there are updates and FAQs. And now here are the data tools. This is where I would encourage everyone to just go look at what's available here. The data browser, like I said, shows you real quick. You can see the different kinds of data that's available. So there are electronic health data domains that's available. You have over 25,000 medical concepts, drug exposure, so the kinds of medicines people are taking, over 29,000. There are labs and measurements, procedures. If you were curious about a surgical procedure, if you were curious about C-sections or epidurals, whatever it is, that's a medical procedure, there are those, you can search those, and we have those from 242,000 plus participants. So it's very large data sets. If any of you has ever done any research, you know, by the time you're able to get 100 people, you're happy. These numbers let you actually answer really big, important questions that can be applied across a broad range of people and make real impact. And then there are genomics type data. We have data from 245,000 plus participants, so pretty significant. And then the survey questions. I wanted to kind of play around here for a second so you could see the kinds of data that's available. So let's do social determinants of health. I hope you can still see what I'm sharing. Can you see social determinants of health? Let me go back here. Good, you can see it. So let's go down here and see. There are over 100,000 people who have completed the social determinants of health surveys. And these are the kinds of questions that people have answered, right? Where I live, people are willing to help their neighbors. My neighborhood is safe. There's graffiti in my neighborhood. My neighborhood is noisy. My neighborhood is close to train stations. We have lots of apartments in my neighborhood. So think about it. If you wanted to ask questions around neighborhood safety and its impact on, say, or neighborhood transportation and its impact on the child's health outcomes or asthma levels or different things like that, you could make that kind of correlation and see if it's telling you anything. You know how you live somewhere and you observe something, but you don't have the ability to find the data to answer or ask what you want to ask and answer. This data provides you that capability. It's a very powerful data source. I hope it comes across to you. I'm really encouraging people to look at. There are facilities in my neighborhood like special lanes, separate paths or trails that support by using your bicycle. My neighborhood has low cost or recreation facilities, and you can kind of see what that looks like. Crime rate in my neighborhood makes it unsafe to go on walks during the day. I mean, we know what they say about your zip code being just as predictive of your health outcome as your genetic code. So being able to use this to explore and answer questions that you may find relevant, I think is really amazing. So having talked about that, let's come back here. Data access tiers. I think I was in Data Explorer. So as of today, or June 19th, 814,000 participants in the program. Organizations that are funded. These are the different areas where people have donated samples from. This is what diversity looks like. So race, ethnicity has dropped. And we can talk about what that means or why that is happening. But in terms of race, ethnicity, you see what the numbers look like. White population, 52.4%. Asians, 3.2. Black or African American, we have about 92,000 people in there. It's 16.6% of the overall, all of us participants. And for Hispanic Latino, it is about 16%, and on and on. People who identify as more than one race, or people who prefer not to answer or classify themselves as other. All right. So let's see if you could. Oh, I wanted to share the types of studies. So let me go back up here and we'll return to data methods, discover research projects directory, and the spotlights. So let's see. Okay, my internet is playing with me. Let's return to the slides, please. I should stop sharing, right? All right, so next slide, let's just keep going. We've gone over all this now, keep going. So this is static, keep going. Keep going, keep going. Yes, so I see a nice question in there. This is an example of a study of a researcher that did work looking at disparities in reproductive health. Basically, she wanted to answer that question, why are we seeing this? And she had a hypothesis, and she used the data to explore this. So when the data was being accumulated with all of us, we had to test it to make sure that we could use it to answer questions. So this was one of those demonstration projects. She was trying to understand how she could, what is the explanation for disparities in reproductive health and outcomes. So she was a researcher that was spotlighted for her work. Next slide, please. The research is currently underway, almost 5,000 active projects. There are over 390 publications. The top conditions being studied right now: cardiovascular diseases, hypertension, cancer, mental health, diabetes. You can add to this whatever you're interested in answering. You can come in here, get a group together, first look at the data that's available and see what it tells you, and then you can take it to the next level. Next slide, please. And by next level, I mean, next slide. If you wanted to actually get into doing analysis in the All of Us Researcher Workbench, what it's going to take is knowing how to do R. I'm a clinician. I don't know how to code in R. There might be people on here who are facilitating using R. So you can create a team, or you can take some basic training on how to do so. All of Us is also supporting getting people from diverse backgrounds the skills and the ability to do analysis using All of Us research data. Next slide, please. This is just one of those programs that's run out of Morehouse School of Medicine as part of the Research Centers and Minority Institutions program, the RCMI program. It's done, it's remote, so you could sign up for it online, but it's like an introductory course to R. There are several others that are available. So if you're someone, someone, or you're someone that wants to do this level of analysis, you can reach out and we will connect you with resources that could help you get to what you're trying to get done. Next slide, please. Next slide. And so I hope that in this conversation, I've been able to share what the All of Us research program is, what its goals are, what that data looks like that exists, and the possibilities in terms of what we could ask and answer and who could ask and answer, what the tiers for access look like. And I hope that I've created an interest in you to want to go deeper, one, to participate, but also as a donor of samples, but also as one that uses that data to make sense of our health and push us to that place where we have the health outcomes that we want. Next slide, please. This is what All of Us Consortia look like. It's a lot of people in a lot of different places doing a lot of different things. There are the participant center partners, there are HPO networks, so we're in the HPO network. And then there are the Participant Technology System Center. Some of that is going to change. There are the people doing the genomic analysis, so very large nationwide effort. It's important, in my opinion, and in many people's opinion, and it's creating this resource that can make significant change. It probably won't answer every question, but it can answer many questions. Next slide, please. These are some of our community partners. Next slide. And this is our team at Morehouse. We have partners at Grady. They do the work every day. They make sure that the data that we've contributed to the program, which is over 5,000 individuals, close to 5,500 core participants, which means they've done every element of the program. And also they're over 90% race, ethnic minorities is who Morehouse has contributed to the program. Next slide, please. Next slide. This is one of our face-to-face meetings. You can sign up for an All of Us newsletter by scanning this or going to this at the bottom of the page, allof-us.org, to sign up for the newsletter. Next slide, please. Next slide, please. Yes. You can set, hang on, keep that up so people know how to sign up through us. The previous slide. Yes. This is how you can connect with us. This one at Morehouse. You can scan the QR code, or you can call that number, or you can email all of us at msm.edu, or you can follow us. So thank you for your time. I see there's very active conversation going on. Kwe, well, how should we handle this? I'm not hearing you.
I was muted. That's why.
Okay.
Sorry about
All right.
that. We're going to
Not a problem.
start with some questions that came in ahead of time. So why don't we start with those, and then we can move to any questions that we see in the chat. So I guess the first question is, other than wonderful events like this one, thank you so much, by the way, for that presentation. Very detailed and very thorough. Really, really appreciate it. It gave us a good overview of everything. How can we disseminate reliable information to our community in order to foster trust in the medical community so that we, women of color, may receive equitable care?
That's a great question. I think it's at several different levels. So events like this or programs like this where we get to, I think the value in this kind of conversation is giving people the tools to understand what's possible. I think in the end, when a person as a consumer is fully empowered, that is the surest bet. That is the way that we can guarantee that when we get information, when we approach healthcare, that we know what we're asking for. So there's that. I think that I can't say enough how important it is to find yourself in situations or in organizations that are very, very mindful of just making sure they're bringing quality information. It's not all information that is what it should be. And so making sure that when you listen and you take in information, that you can scratch the surface and convince yourself that that information is authoritative and authentic, right? Because these days, with the democratization of how information can be shared, it also opens the door to just all kinds of information being shared, whether it's real valid information or not. So equipping yourself with the tools to know how to tell the difference, I think, is the key.
And that's super important. Being able to, taking everything into your own filter and being able to decide what's relevant, what's most important, and what's valid, as opposed to information that maybe hasn't been substantiated or sourced.
Right.
Yeah,
right.
That makes a lot of sense. Talk to us about how this program works for pregnant women.
It works in that anyone can participate in it. So the data that currently sits there. So for instance, if someone wanted to do research on people who are pregnant to see what in general are who's getting pregnant, we kind of know who can get pregnant, but what kinds of health conditions are affecting women who get pregnant in this day and age. You can go in there and see what health conditions for people who are pregnant, search by people who are pregnant and health conditions, and see what's showing up. You can also try to understand outcomes when people are pregnant and they have a baby, what kinds of outcomes, because there's electronic health record information. So anyone who participated and gets pregnant, their information is in the EHR. If they participate in the program, that information is available for analysis. So the way the electronic health record information works is, once I'm signed up for all of us, all of my health progression, basically, the EHR data keeps getting refreshed. I think it's every month it gets refreshed. So new things come in. It's not static at the time that I join.
That's interesting.
So
that's very interesting.
It gets refreshed. It gets refreshed. And so you can have a longitudinal view of a person's health journey, right? So not just at one point in time, but prior to getting pregnant. So for people who are interested in understanding, for people who present with this kind of problem when they're pregnant, can we tell something earlier on
Mm.
that could help us develop interventions to make them less at risk? Because the point of precision medicine is we want to apply cures in a way that's tailored to that person. We don't want to find out after the fact that this happened to this person and they responded in this way to this intervention. We want to know up front, I'm meeting you, Quay. Hey, you have these characteristics. This is how we should manage this condition. Does
Yeah.
that help?
Yeah, yeah, very, very helpful. So speaking of precision medicine, how do we better understand how precision medicine can help with maternal health disparities in women of color?
Can I give an example that's not maternal health and you kind of see if that helps paint the
Sure.
picture? Okay. So I don't know if your audience, most people kind of have, because we have moms and we have dads and older relatives. Um, there's a medicine called Plavix,
Mm-hmm.
clopidogrel. Very common. A lot of people take it. In general, we use clopidogrel in medicine because it prevents your platelets. These are little cells in your blood that are sort of in the first level of how your body creates a blood clot. So Plavix blocks platelets from clumping together, so it prevents clots from forming. Now, the first time we started to use Plavix, it was in people who had heart procedures. You know, if you have a heart attack, there's narrowing in your heart vessels. They go in and they put in a scaffold or a stent. When they put in that stent, your body wants to form a clot because it recognizes it as foreign. So they give you Plavix to keep it open. Well, there was, they did the studies, it was approved, it was out in use, but people of um, like Pacific Islanders, they were not well represented in the study. And we started to see people show up in the emergency room after taking Plavix, but still having chest pain, still looking like they were having their stents clotted over. And at first, it was like, are you sure you took your medicine? Yes, they took it, but it wasn't working. Why was that? Because it turns out they have a version of an enzyme that doesn't break down Plavix. When you take the pill Plavix, it's in a pro form. Your body has to work on it for it to become the active drug. And not having that enzyme form, they were taking the pill, but it was just passing through them. It wasn't being converted into the active form. And so they were not able to benefit from it. If they had been part of the studies, or if we had known this like we know it now, I mentioned earlier that when you do all of us, you get a pharmacogenomic profile. A pregnant person is a person. They get their pharmacogenomic profile. So they know this is how my body handles different kinds of medicines. So when those decisions are being made about medicines that you should be on, you already have tools at your disposal. So we're not doing the trial and error thing and trying to figure out after the fact whether this was good for you or not. Is that helpful?
Yeah, that's very helpful. I'm looking at the time. Unfortunately, we are at time right now. It is 10 o'clock Eastern. So we are going to bring this to a close. Dr. Pemu, I wanted to thank you so much for joining us this evening. Very informative presentation. I hope that those of you all who are watching got something out of it. I'm sure you may have more questions. We are connected to this program, so if you have any questions, please let us know. We're happy to share the questions and see if we can get answers for you. I want to thank everyone for joining us this evening. Dr. Pemu, thank you so much for talking to us and answering our questions. To learn more about the All of Us Research Program and how you can become involved, please visit bit.ly/Mocha Moms AOU. I want to thank everyone for joining us tonight, and we will see you next time. Take care.
Thank you, Clay. Have a good evening.